The following set of slides relate to psychological aspects of care. This refers to step 1 competencies for nurses of promoting a positive patient experience. Part 4 and 5, what do we do? So this is about the importance of developing trust, using communication and individualized care, and assisting patients to regain control and be involved and empowered where possible in their care. This is where the helpful concept of humanizing the ICU comes in. So this is where we enable visitors, we concentrate on communicating well with the patient, we think about the broader well-being of the patient, not just their physical needs. We encourage relatives and loved ones to participate in the care for the patient. It's also about caring for you guys so that you have the resources to care for patients well. Please look at some of our other videos about self-care for staff in ICU. It's also about prevention, management and monitoring of post-ICU syndrome, and within ICU having the kind of architecture and infrastructure that thinks about people's experience and a good end-of-life experience. So here are the C's of promoting psychological well-being. Comfort. Ask yourself, is my patient physically comfortable? Are they hydrated? Is there anything that could be affecting them, such as constipation, pain, or their physical position? Are they emotionally comforted? Do they have access to cues of familiar, things like photos from home, visitors, and how they're responding to my words and touch? Certainty. What certainty can I offer my patients? When will the ward round occur? When will they have a wash? When will the physio come? What's happening to their health and recovery? Control and choice. What elements of control and choice can I offer my patient? For example, these may be simple things: the radio on or off, if the bed's able to be turned to face the window or not, to be in bed or sat out in a chair. And thinking broader than that, what meaning and purpose for life is important to the patient? How can I bring some of these wider things into the simple parts of my care? For example, if my patient follows the news, can I read a newspaper to them or let them listen to the news on the radio? If my patient enjoys caring for pets, can I show them photos of the pet? Can we allow the therapy dog to come and see the patient? Communication. How do you communicate with your patient? Have you involved the speech therapy team? Can they mouth words? Are they consistent in their yes or no response? And if we can't yet fully communicate with the patient, we communicate with the relatives to understand the patient's world. And then lastly, connection. This is seeing the wider patient. Can you enable the patient a connection to life outside of the ICU? Is that through visitors, photos, use of familiar objects, etc.? Some simple actions. You can encourage activity, even if that activity is just conversation. You can improve sleep through clustering care at night. You can manage noise and light levels throughout the day and night to enable this. You can offer reassurance, choice, control, structure, communication, connection. You can offer encouragement. Some of that encouragement is through goal planning the day and the week with the patient. And most of all, you can understand and normalize how hard it is to be in their position. When building trust, just be aware of what provokes your own anxieties and what might feed off the anxiety of the patients and the relatives. But mostly it's about demonstrating that you're a safe pair of hands through reassurance, being calm, explaining things as best you can, distracting patients from the harder aspects of care, and talking about things outside of the hospital. Simple ways to humanise the person include using the Read About Me paperwork. You can encourage the relatives to bring in photos and other things from home. You can use the patient's own clothes, and you can keep orientating the patient to news and outside world events. When we think about communication, we need to first think about all the practicalities. Does this patient need glasses? Does this patient have a hearing aid? Is there a better side of the bed that the patient prefers for you to be? What about enabling a physical voice through a speaking valve and working with the speech and language therapy team? The speech and language therapy team can also offer communication packs and whiteboards. Be aware that the patient is likely not to be fully cognitively capable in the early days post-desedation, and also if there is any delirium. So keep your language quite simple and straightforward. Offer questions with a yes/no response if the patient doesn't yet have a voice and you're struggling to lip read. As we've already said, control and choice and reassurance and care are key fundaments to communication. In essence, treat them like you would want a member of your family treated. Any member of the nursing or medical or allied health professional therapies team can goal plan with the patient. It's about the patient, not about the staff member. Remember that our goals might feel different to a patient's goal. So when we're talking through goals with the patient, we need to orientate it to what matters to them. For example, our goal might be for the patient to wean off the ventilator, but a patient would see it as breathing independently again. Our goal might be for the patient to sit on the edge of the bed, but a patient goal is to get stronger and get out of the ICU. So wording is very important. There is some evidence to say that post-ICU, the use of a patient diary within ICU can reduce psychological distress. This is because it enables patients to fill in the gaps of what happened in intensive care. Diaries are returned at the intensive care follow-up clinic. Enabling acceptance and grieving is part of enabling patients. It's important to know it's likely to take a patient some time to make sense of what they've been through. Beware of dismissing the patient and that vicious cycle of distress expression. A patient in discomfort will express distress, but if our reaction is to say, it's fine, don't worry, some patients will actually increase their distress because they don't feel that they're being heard. Listening and asking, what's your concern? What can I do to help? Can reduce the symptoms of distress in patients. We think of grieving in terms of loss, but also grieving in terms of loss of ability. So the kinds of emotions you might see in patients and also their loved ones are a sense of denial or a lack of acceptance, anger, bargaining, and sadness. All of these are normal emotions and do not require any interference. What they require is time. It's important that grief is not linear. We think of it as experiencing two parallel sides of yourself, the part of yourself that's experiencing grief and the part of yourself that's avoiding grief. And people often bounce between the two. So there will be times when patients will be wanting to talk to you about their distress, and there'll be times when the patient will want to joke with you or say something different. This is the same for their loved ones too. This may be the same for you witnessing grief. This is a normal process. Some people become agitated towards the end of their life. There are a number of different causes, and it can be recognized by restlessness, fidgeting, and changes to a patient's behavior. Patients who are agitated may struggle to communicate how they're feeling. They may become fatigued or confused. It's important to check their symptoms. Check if there are any reversible causes of their agitation and try to communicate with them where possible. Use moments when they are calmer and less agitated to speak to them. You can support the patient by asking something like, "I can see that you're feeling unsettled," and ask open questions and encourage them to express what they're thinking and feeling, and speak clearly and calmly. Patients' relatives following the death of a patient are likely to take quite some time to recover. Often we feel like we'd like to offer them something to get through this difficult time. There are leaflets on the unit and there's a bereavement follow-up service. But some simple actions include reminding people to take time, staying connected to their loved ones, to allow themselves that passage of time and allow the emotions to flow, allowing themselves to remember their loved one, but also saying goodbye and allowing symbolic endings.